When genetic errors accumulate in the female reproductive system, mutated cells divide relentlessly, invading healthy tissue to form lethal malignancies. The clinical stakes are severe. Ovarian cancer is the fifth most common cancer in women and the fifth leading cause of cancer-related death among the female population. This diagram illustrates those primary origins. Depending on where the initial mutation occurs, a neoplasm can originate from the surface epithelium, the germ cells, or the sex cord stromal cells. To accurately predict clinical behavior, researchers must map these tumors against their cellular origins, a process that requires adapting to new evidence regarding where these cancers truly begin. This data visualization isolates the epithelial tumors, showing their dominance in the pathology landscape. They account for 65 to 70% of all ovarian tumors, and in their malignant forms, they are responsible for 90% of all ovarian cancers. This gross medical photograph shows a benign serous tumor, the most frequent subtype. These present as large, smooth cysts filled with a clear serous fluid. This histological micrograph details the inner lining of that cyst, relying on a single layer of columnar epithelium. At the tips of the papillae, pathologists consistently look for psammoma bodies, calcified concretions serving as a distinct diagnostic marker. Borderline serous tumors display more complex architecture and mild cytologic atypia. Crucially, they lack stroma invasion, keeping their clinical prognosis intermediate between benign and malignant types. Tracking this morphological progression from benign to borderline is essential for diagnosis. Yet this slow, sequential evolution only accounts for one specific pathway to malignancy. Ovarian serous carcinomas are divided into two distinct tiers based on their development. The first pathway involves low-grade serous carcinomas, which evolve slowly directly from borderline lesions. This low-grade pathway is primarily driven by genetic mutations in the BRAF and KRAS proteins. The second pathway yields high-grade serous carcinomas. These tumors develop rapidly with severe cellular atypia and immediate aggressive behavior. This comparison demonstrates the physical contrast. On the left, low-grade carcinoma maintains differentiated structure. The high-grade carcinoma on the right displays chaotic architecture and invasive stroma. These chaotic cells result from distinct genetic errors, specifically TP53 and BRCA1 mutations, disabling tumor suppression. These differ from mucinous ovarian tumors, which secrete mucin, do not form psammoma bodies, and are primarily driven by KRAS protein overexpression. The distinct genetic drivers between low and high-grade serous tumors dictate entirely different clinical timelines. The rapid onset of high-grade disease prompted researchers to look outside the ovary itself to find its true origin. For decades, the medical consensus held that all epithelial tumors arose from the coelomic epithelium covering the outer surface of the ovary. Recent evidence indicates that high-grade serous carcinomas actually originate as serous tubal intraepithelial carcinomas, or STICs, within the fimbriated end of the fallopian tube. Malignant cells shed from the fimbriated edges of the fallopian tube, migrating through the open pelvic space to seed themselves directly onto the ovarian cortex. This slide outlines the genetic proof linking these sites. STICs share the exact same TP53 mutations found in 90% of high-grade ovarian carcinomas. Beyond serving as the origin point for these malignancies, the fallopian tube is also the primary site for ectopic pregnancies, making it a critical structure in multiple severe gynecologic conditions. Reclassifying these malignant tumors as tubal in origin significantly alters how oncologists assess patient risk, especially for women carrying inherited BRCA mutations. Returning to the classification chart, we find the germ cell tumors. As highlighted by the red circles, this category affects a distinctly younger demographic, primarily women between the ages of 0 and 25. This slide details how germ cell tumors are categorized by their cellular differentiation. Dysgerminomas differentiate toward oogonia, while choriocarcinomas differentiate to mimic placental tissue. The most structurally complex of these are the teratomas. They derive from totopotential germ cells, meaning they retain the genetic capacity to form mature tissues from all three embryonic germ cell layers. Because of this totipotency, mature cystic teratomas develop bizarre gross pathologies. When excised, these cysts are frequently filled with sebaceous secretions, fully formed hair, bone and cartilage, and even teeth. The weight of these mature tissues creates a mechanical risk. The mass frequently causes the ovary to twist on its supporting ligaments, cutting off local blood supply and triggering severe abdominal pain. While their gross appearance is alarming, over 90% of mature cystic teratomas are benign. The primary threat to the patient is mechanical torsion rather than metastatic spread. Across this diverse taxonomy, the clinical presentations share similar vague symptoms. Patients often report general abdominal pain and gastrointestinal complaints, with rare exceptions for hormone-secreting tumors that trigger endocrine imbalances. These varied pathologies all exploit the same anatomical vulnerability. The fallopian tubes and ovaries sit completely unencapsulated within the open space of the pelvic cavity. This unsealed structure gives malignant cells direct access to the peritoneal cavity. Whether shedding from a stick or the ovarian surface, cancer cells detach and drift outward, implanting directly onto the omentum and the expansive peritoneal walls. This direct anatomical access dictates the clinical reality. The cancer spreads silently across a massive surface area, typically presenting symptoms only after advanced ascites, the accumulation of fluid in the abdomen, has already formed. Treatment requires aggressive surgical resection combined with chemotherapy. However, despite identifying the genetic drivers and structural origins of the disease, medicine still lacks an effective early screening method. Decades of research have successfully mapped the molecular taxonomy of ovarian neoplasms. Yet, these cancers remain highly lethal because local anatomy provides a direct, silent highway for systemic spread long before clinical detection is possible.